SGLT2 inhibitors in type 1 and type 2 diabetes, a logical therapeutic choice. This video is based on several research articles published on PubMed, Medicine Plus and some other sources. Main points I want to point are: insulin treatment is costly in most countries. It is also cumbersome, not easy as taking a capsule or tablet. Risk is causing a hypoglycemia or hypo is high, and unrecognized or not treated hypo can be fatal. Major issues caused by SGLT2 inhibitors are mainly urinary tract infections and ketoacidosis. I believe both can be managed if the required steps like checking blood sugar level is done by the patient. I personally have been taking Jardiance, a SGLT2 inhibitor, for the last 10 years or so, and I have never encountered any of the above issues. A new medication called sotaliflozin, which is a dual sodium glucose co-transporter 1 and 2 inhibitor for the management of type 1 and type 2 diabetes mellitus, has been approved in Australia by TGA in Australia, up to my knowledge. I have a hope that will be a much better option. Disclaimer: consult your health care professional before making any changes to your medication or lifestyle. I have been suffering from type 2 diabetes for the last 40 years, and I have been pushed into taking insulin by some endocrinologists. Luckily, at around the time TGA approved in 2014 for the treatment of type 2 diabetes mellitus to improve glycemic control as an add-on combination therapy with other glucose-lowering medicines. If you want to know more about SGLT2 drugs, see the video link above. I have been taking Jardiance since then, and it saved me from the hassle of injections. Not to mention the cost saving of probable few $1,000s per month. SGLT2 medications work by releasing the excess glucose in the blood through the urine. So my understanding is, while you are taking SGLT2 drugs, you need to control your blood sugar levels by other means as well, like reducing carbohydrate intake, doing regular exercises and being active. Subscribe to my channel if you want to know more. While we are in the middle of the video, see the references on the description page. Do not forget to comment, share and like my video if you find that useful. SGLT2 inhibitors demonstrate potential for enhancing metabolic and cardiovascular health in individuals with type 1 diabetes, but selecting the most suitable candidates for this therapy necessitates and requires careful consideration. The advent of sodium glucose cotransporter 2 or SGLT2 inhibitors, including empagliflozin, dapagliflozin, canagliflozin, and ertugliflozin, has revolutionized the management of type 2 diabetes. Pivotal trials have underscored the significant cardiorenal benefits of this drug class in type 2 diabetes patients. Interestingly, these profound advantages emerged largely as a result of a regulatory requirement set by the United States Food and Drug Administration in 2008, mandating cardiovascular outcome trials for all new type 2 diabetes medications before their clinical use. SGLT2 inhibitors have transcended their traditional usage within endocrinology, now becoming essential in various medical specialties. Their indications have recently expanded to encompass heart failure with reduced ejection fraction and kidney disease, extending even to non-diabetic individuals. This expansion is not unexpected given that their mechanism of action operates independently of insulin and blood sugar levels. By inhibiting renal tubular glucose reabsorption, these inhibitors induce glucosuria, leading to their glucose-lowering effect. The mechanisms underlying their cardiorenal protection likely involve improvements in glycemia, insulin resistance, lowered plasma urate levels, and reduced epicardial fat volume. Consequently, they mitigate cardiac inflammation, enhance contractility, and induce natriuresis-related hemodynamic effects that impact blood pressure, intravascular volume, sympathetic activity, and tubular-glomerular feedback. Wait, there is more. But do not forget to hit the like button and subscribe, down below. However, these actions also elevate the risk of genitourinary infections, including necrotizing fasciitis of the perineum and acute kidney injury, warranting caution in individuals prone to severe or recurrent genital infections, hypovolemia, or ketoacidosis. Given the diverse range of direct and downstream mechanistic effects, it is conceivable that this class of drugs may find applications beyond type 2 diabetes. Sodium glucose co-transporter 2 or SGLT2 inhibitors help people with type 2 diabetes in many ways, like lowering blood sugar, losing weight, lowering blood pressure, and reducing the chances of having serious heart problems. Because there's a big need for better ways to control blood sugar, scientists have been studying if these SGLT2 inhibitors could also work for people with type 1 diabetes, especially when used alongside insulin treatment. In this video, we talk about data from 8 studies that looked at how well canagliflozin, dapagliflozin, empagliflozin, and sotaliflozin worked for people with type 1 diabetes. They found that these drugs lowered a measure of blood sugar HbA1c the most after 8 to 12 weeks of using them. But over longer times, up to 52 weeks, the blood sugar lowering effect wasn't as strong. We still don't know how well these drugs keep working over a long time in people with type 1 diabetes. But there are also some problems with using SGLT2 inhibitors. One big issue is that they can increase the risk of a serious condition called diabetic ketoacidosis or DKA. The U.S. Food and Drug Administration estimates that for every 26 years a person with type 1 diabetes uses sotaliflozin, there will be one extra case of DKA. If we assume that 0.4% of people who get DKA will die from it, this means there could be 16 more deaths every year for every 100,000 people with type 1 diabetes who take this drug. All these things make us wonder if the benefits of using SGLT2 inhibitors with type 1 diabetes patients may outweigh the risks. The predicted metabolic benefits of SGLT2 inhibition in type 1 diabetes were demonstrated across 3 phase 3 clinical trial programs: EASE empagliflozin trial, DEPICT dapagliflozin trial, in tandem or sotaliflozin trial, a dual SGLT1 and 2 inhibitor. Weight loss is usually in the order of 2 to 3 kg and glycated hemoglobin levels typically improve by up to 0.5%, importantly, without increased hypoglycemia risk. Recognizing these benefits, the European Medicines Agency or EMA approved dapagliflozin 5 mg in March 2019 as an adjunct in the treatment of individuals with type 1 diabetes with overweight. Subsequent real-world studies from Europe found improved glycemia without the expected increase in insulin dose that is required to achieve normoglycemia, and without the weight gain that is usually observed with treatment intensification. While the EMA's decision was celebrated by diabetologists across the globe, support was not replicated by the FDA, which declined applications for dapagliflozin and empagliflozin largely due to risk concerns. Do not forget to click the like button and subscribe. Up above you see a video related to health. It will be more helpful to you and your family. Subscribe to my channel.